My name is Sadie Thompson, and my case study is on subclavian still syndrome. There are two types of subclavian still syndrome. The first I'll talk about is vertebral, and that phenomenon occurs when a subclavian artery occlusion or high-grade stenosis proximal to the vertebral origin causes retrograde flow in the ipsilateral vertebral artery. The blood pressure in the subclavian artery beyond the point of the occlusion or distal to the occlusion is decreased, and when the blood pressure is dropped, the flow in the vertebral artery will reverse and subsequently steal blood from the unaffected subclavian artery through the contralateral vertebral artery. This still is necessary to provide adequate blood supply to the affected arm. The second type of subclavian still syndrome is coronary, and it's very similar to vertebral subclavian still syndrome, except different arteries are used. So instead of stealing blood from the vertebral artery, it steals blood from the internal mammary artery, and that artery is considered the superior conduit of choice when myocardial revascularization is performed. The IMA originates from the subclavian artery just distal to the vertebral artery, and coronary subclavian still syndrome occurs when an occlusion or stenosis proximal to the IMA ostium, so where it meets the subclavian artery, causes a reversal of flow in the ipsilateral IMA coronary artery graft. And coronary subclavian still syndrome can cause angina, acute coronary syndrome, arrhythmias related to myocardial ischemia, and cardiac arrest from ventricular fibrillation. The case study that I found was based on an 80-year-old male that presented with vertigo. He had a history of hypertension and smoking, and the labs that were drawn were a fasting lipid panel and CRP. The CRP evaluates inflammation in the arteries, and the imaging that was performed was an ultrasound and an MRA, and ultrasound images demonstrated retrograde flow in the left subclavian artery, and MRA images confirmed the presence of a clot or an occlusion. So both the right and left vertebral arteries were evaluated using ultrasound, and the right subclavian artery demonstrates normal antegrade flow, which is represented in the red with a normal waveform. So these pictures are of the left side, and the bottom picture demonstrates the color Doppler of the left vertebral artery, and it's blue due to the retrograde flow. And then the top picture is of the left brachial artery, which demonstrates a monophasic waveform. And these findings indicate there's a high-grade stenosis or occlusion in the left proximal subclavian artery. Okay, after ultrasound, an MR angiogram was used to confirm the presence of an occlusion in the left proximal subclavian artery, which is shown with the yellow arrow, and blood is supplied to the distal subclavian artery through the vertebral artery, which is what the red arrow is pointing to. Okay, the most common cause of subclavian still syndrome is atherosclerosis or atherosclerotic disease. Other causes may be aortic dissection, Takayasu arteritis, radiation arteritis, thoracic outlet syndrome, ipsilateral arteriovenous fistulas, and congenital heart irregularities. And the risk factors are those that would be associated with atherosclerosis. So those include smoking, hypertension, hyperlipidemia, diabetes, increased age, and family history. So subclavian still Most cases of subclavian still syndrome are asymptomatic, so it's typically an accidental finding. However, symptoms that can occur include vertigo, impaired coordination, blurred vision, hearing loss, syncope, or slurred speech, and those symptoms can occur because the brain isn't receiving enough blood because it's being directed to the arm instead. Symptoms that can occur in the ipsilateral upper limb include arm pain or discomfort, numbness, tingling, a weak or absent pulse in that arm, an arm blood pressure difference greater than 20 in the affected limb, and cramping. And in coronary subclavian still syndrome, symptoms are related to myocardial ischemia, so that could include angina or heart arrhythmias. The imaging modalities that are used to diagnose and identify subclavian still syndrome include ultrasound, CT and MR angiography, and digital subtraction angiography. Ultrasound is typically the standard bedside screening tool. It demonstrates retrograde flow using duplex and color Doppler, and it's complemented with MR and CT before treatment. So CT and MR angiography are usually ordered after an abnormal finding is found on an ultrasound, and they're used to confirm the presence of an occlusion or stenosis, and they can also identify intra and extracranial cerebral vascular lesions. And then digital subtraction angiography is the gold standard. It's typically used before treatment, and it helps depict the anatomical features and severity of the stenosis or occlusion. The severity of subclavian still syndrome is classified according to the extent at which blood flow is disturbed. It's classified by 3 grades, grade 1 being pre-subclavian still syndrome, and that's when there is reduced antegrade arterial flow. Grade 2 is intermittent or partial subclavian still syndrome, so that presents as antegrade and retrograde arterial flow. And grade 3 is permanent or advanced subclavian still syndrome with permanent retrograde arterial flow. Subclavian still syndrome is seen in about 0.6 to 6.4% of the general population. It's more prevalent in men, and there's an increased incidence with age, especially above 50 years of age. It's also 4 times more likely to occur in the left subclavian artery, and that's attributed to the acute angle of origin between the left subclavian artery and the ascending aorta. Only a small percentage of those diagnosed with subclavian still syndrome need therapeutic intervention, and treatment is based on the severity of the occlusion or stenosis and the symptoms that the patient presents with. Some patients can try antiplatelet therapy or oral anticoagulation before undergoing surgery. Interventions include endovascular, which can include percutaneous angioplasty. That's when they insert a balloon into the artery to open up that occlusion or that space to allow blood flow to enter back in, or a stent can be placed. Other surgery includes revascularization, so they can undergo an axillary to axillary bypass or a carotid to subclavian bypass, or there's also carotid to subclavian transportation. Subclavian still syndrome is a relatively benign condition, and the prognosis is usually very good, especially when symptomatic patients undergo surgery. They typically yield a good prognosis. However, some underlying causes of subclavian still syndrome can lead to serious or life-threatening complications if they are not managed correctly or treated properly. The differential diagnoses for subclavian still syndrome include peripheral artery disease of the upper extremity, posterior circulation stroke, aortic stenosis, or diabetic neuropathy. And these are just my references. Thanks for watching.